Okie dokie. Let's just make sure everything is looking good. And then once it's looking good, we will go ahead and get going. Let me just double check here. Go here. We're going to go here. We're going to go like that. We're going to go like that. We're going to go like that. We're going to go over here. All this fun stuff. Getting ready fun stuff. Making sure it's okay. Making sure everyone can hear. Everything is okay. Let me just share this on ye old Twitter or X or whatever you call it, whatever the kids call it nowadays. You know, and once we get it all shared, we will get the show on the road. On the road. We're going to get this show on the road real quick here. Real quick like. So bear with us. Okay. Here we go. We're almost there, I swear. Almost ready. Okay. I think we did it. I think it's been shared. And because I think it's been shared, I think it's time to get going. Good afternoon, good evening, good morning, whoever you are, wherever you are. This is Dr. Patrick Lockwood. I guess Patrick, for the purposes of this, please don't sue me. This is the UnShrink Me podcast. And today we have oh so many fun things to talk about. This episode will be talking about psychedelics and psychedelic-assisted therapy, ketamine, psilocybin, MDMA. Also be talking about masculinity because it seems to be a topic that many people are interested in at minimum. And so my hope is that, genuinely speaking, you know, we can have some reasonable thoughts about masculinity in today's episode. I'm also going to be talking about the concept of stupidity. Now, that word has a lot of negative connotations. People seem to think words like idiot and moron and retard are extremely derogatory. And so there's a segment of people who hate those words and think they're slurs. There's a segment of people who think they're just fine, and so on and so forth. And so today we're going to talk about intelligence and why it matters and doesn't matter and what it can look like actually in a mental health context. And we'll also talk about what it means to be a good therapist, as always, because for those of you who are new to UnShrink Me, just so you know, my main focus, my main goal, genuinely speaking, is to provide as much information and my own experience as a clinician, as a professor, as a supervisor, as a treatment center operator, all these backgrounds I have to help you become a more informed consumer of mental health services. That is my only job. My only job here is to be entertaining and talk about what's not really popularly talked about in pop psychology about mental health, because there's a lot of misinformation. There's a lot of people who don't understand the science of psychology, the science of treatment, the science of therapy, and there's a lot of people who believe a lot of woo, and there's just a lot of mediocre people who have a lot of ideas that aren't confirmed and supported. And so my genuine hope for everyone is that you get something useful out of every episode that might influence the type of therapy you seek out, how you relate to your therapist if you have one, if you choose to get one, so that you can make a more informed choice. That's it. That's it. I'm not anti-therapy and I'm not pro-therapy. I'm pro-good therapy and I'm anti-bad therapy. And that's it. And I have a reputation that supports my opinions and perspectives. So I'm not standing on shaky ground. I'm not standing on just my biases. So this is UnShrink Me. let's dig into it. So, as always, for those of you who don't know, I am not N-O-T, not formally sponsored by Celsius, but this is great stuff. So, extremely grateful for Celsius. So, the first thing I'd like to discuss today is a post by a researcher named Eiko Fried, and I'm going to retweet it right now so you can all see it. Okie dokie. So Eiko Fried, if you don't know him, is a really smart, in my opinion at least, researcher who posts really great like philosophy of science and critiques of psychological science. So this is a person who, as an expert, as a researcher, is good at critiquing statistically and otherwise scientific papers in psychology. And so Eiko put out this post 5 days ago that I want to talk about right now because, psychedelics are very trendy. Joe Rogan, I think, just had Paul Stamets, who's a psychedelic researcher, on his podcast. And so I want to speak at length, or maybe more briefly actually today, about psychedelics and why they're useful and why they're not useful. But I want to start with Eiko's post. So there's a preprint, which means that it hasn't been formally accepted for publication yet. But a brand new paper that's coming out in the near future discusses the research on psychedelics and depression. So when this first became popular in the mid-2000 teens, 16, 17, 18, etc., there was research out of major universities like Johns Hopkins, etc., that showed that like a single macrodose or heroic dose of psilocybin or mushrooms helped people substantially with depression. And there was similar kinds of studies that have come out since then. And so it's all the rage in the psychedelic world to look at psychedelics, mushrooms, MDMA, ketamine, all of which is great. I'm not anti-psychedelics. I've used them myself. I think they're awesome. And so my hope is that, genuinely speaking, we can maybe try to find better ways to use these tools if it's possible. But the problem would be is, I think, at least in my opinion, there's very few people that fully understand what these things actually do. Like, the mechanism of action sort of understood, but also not understood, if that makes sense. And so I'm going to pull up his paper here real quick and just talk about what he said specifically and what the stats actually say about psychedelics and their effectiveness for depression. Okie dokie. So his post was, again, 5 days ago, and he said, this is an exact quote of his paper, psychedelics, or not his paper, his post, psychedelic science largely ignored the problem of unblinding, comma, dramatically inflating effect sizes, not even assessed in most of these studies. So there's this brand new study, psychedelics do not outperform antidepressants in a fair comparison where both studies are unblinded. So what he's saying is there's a number of bodies that are buried in the literature on psychedelic-assisted psychotherapy, especially for depression and mushrooms. And one of the problems is that when you have these conditions where the researchers either are or are not blind, as in they don't actually know who's in what group, if they're in the experimental group with the mushrooms or the control group without, or the experimental group with the mushrooms or the experimental group with antidepressants, etc. So if you know where somebody is, it can bias the way you run the experiment, analyze the data, etc. And so what we're finding, what this new preprint says, is that basically when you do a fair comparison where you control for whether or not the conditions are blind, essentially, that actually psychedelic mushrooms do not outperform antidepressants. Now, there are some specific statistical reasons that he goes through why that's the case. I'm not going to bore you with the stats. I retweeted it, so if you want to read the paper, please do. It's interesting. What I will say is there's a general reason beyond even the mechanisms of, neuropharmacology why the mushrooms didn't have a much better result than antidepressants, because Addressing the psychobiology, the neurobiology of any mental health condition is not going to produce lasting behavior change. You cannot exercise away your depression. You cannot caffeinate away your depression, as much as we may try. You cannot mushroom away your depression. You cannot antidepressant away your depression. That's not how clinical diagnoses work. Most clinical conditions, most diagnostic problems, like major depressive disorder, require changes to your physiology, which are important, by the way, and sometimes meds do that, sometimes mushrooms do that. But the problem with changing behavior patterns, and I know this as a clinical psychologist and a professor, is if you read the research on any therapy, is that it takes time to learn to consistently do new things better, right? And this is true across every behavior change you could ever want to do. If you want to exercise better, you can't just exercise good one time at the gym and be like, okay, now I've got this habit burned into my brain and it'll forever be different. That's not how anything works. No human being, or almost no human being, maybe 0.0001% of human beings can have like a drastic trip and be forever changed. Like, I've done psychedelics. Don't fire me. Don't sue me. And they have drastically changed my perception of myself and life and people and love and all these things. And I think they're awesome. And I didn't just magically stay forever exactly the same as I was the first week after the trip and the second week. So you have to, like, the technical word in the psychedelics community is you have to integrate. You have to take these insights and patterns of knowledge and patterns of behavior and integrate them into greater parts of yourself. Integrate them into parts of your habits and your daily life that actually are useful for you. And so the general idea is there's no magic mushroom. There's no magic thing that is going to magically make you feel better and resolve your symptoms of this, that, or the other. The same thing's true for PTSD and MDMA. I know there was a phase 3 trial that just got rejected by the FDA looking at PTSD being treated by MDMA. So the mechanisms make sense at the neurological level. The problem is that it's really hard to control for many, many outside variables, other diagnoses, life stressors, support system, finances, poverty, stress, there's dozens of reasons why it's hard for people to get better when they have a serious mental health problem. And so using this one big leverage point, like a drug or a psychedelic, will shift people temporarily and maybe motivate them or set them on a path. But just because you're set on a path doesn't mean you can't wander off of that path. And so the hard part about psychotherapy and behavior change in general is actually staying on the path. And so that's why having therapeutic support and support groups, mental health support groups, and free support groups like AA and NA and all these kinds of things are super valuable, because all these sources of accountability, like support groups and therapists on the professional side, in some cases, help you stay on the path. And staying on the path is usually a very hard thing to do when you have a history of pervasive trauma or depression or personality disorder or whatever it is. And so there is no magic mushroom that will cure anything. I think psychedelics are great. I think the research is promising. But just because it's promising doesn't mean that people aren't manipulating findings and doing all the same kinds of scientific fraud, usually on the milder end of the spectrum, that is really getting in the way of these things being discussed accurately. So please do not think that just because people like psychedelics and they do good psychedelic research or whatever, that there aren't a bunch of flaws in these studies. There's tons and tons of flaws. And this paper that I retweeted that Eiko Fried was talking about is a perfect example of that. So please, 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 if you know someone who's interested in psychedelics, please be careful. Please, please, please be careful, because it's very tempting to find this giant magical source of relief. And that's not how it works. Let me get to the chat here, because there's a couple of people here. Jonathan Cogburn's here. He sent a mushroom emoji. Thank you, Jonathan. That's what we're here to talk about. And Jake is here. He said, I had great experiences with psychedelics. I also have seen people one-shotted by them. Caution. Yeah, so Jake, I've also had the same experience where I've worked with people professionally, and I've seen people try to do the psychedelic trip experience well and fail because there's a lot of prep work that goes into doing a psychedelic trip the right way. So like haphazardly doing psychedelics, bad for everyone. Definitely don't encourage that. I think that's bad for everybody, literally. What I would say is for the people that might benefit from psychedelics, the prep work is where a lot of the magic is, but also after the trip is where a lot of the magic is. So like, I'm all about psychedelic assisted therapy if the person actually knows what they're doing. So the question many of you might have is like, how do you know if a practitioner actually knows what they're doing, right? So there's two categories of questions that I always like to ask people when it comes to the concept of competence. How competent are you? So question number one, I always want you to be asking your therapists is, how do you know what you know, right? Because a lot of people might say, well, the research says, which is, I think, a terrible cop-out, because that's such a vague phrase. The research says dozens of different things, literally, not metaphorically. So because the research says dozens of different things, you got to be careful when a clinician or professional of any kind comes back at you with the research says. If they don't give you some specific studies and talk about specific types of results and why it worked in those specific cases, then I wouldn't trust that person. Also, maybe they've had some experience with other patients where they've seen promising results. Now, that's not to say that it will replicate and generalize to you. So always ask how it's worked in the past with other people, because it might have worked with other people, and that would be awesome. But again, people, although we are extremely similar biologically in other ways, we're also extremely dissimilar. Fun fact of the day, everyone's brains are built differently. So we all have the same basic big brain structures like a corpus callosum and a thalamus and temporal cortex and all this stuff. But at the level of the cell, at the level of the neuron, everyone's neurons are built differently. Everyone has different densities, to be technical about it, of different types of neurotransmitters and receptors. So some people have 3,000 5-HT2A serotonin receptors, and some people have 200. Some people have 500. Some people have 5,000. And you have no clue what your brain is built like. So you have to be extremely careful when you're trying to like mess with pharmacology, because trying to do these direct actions at the level of the receptor, you don't know what you're messing with. So a lot of these drugs like psychedelics directly influence the receptors, but also your genes, right? Paul Stamets was just on Joe Rogan talking about psilocybin having a psilocin specifically having a direct effect on the nucleus at the genes of your neurons. And so you don't know how you're built. So you have to be extremely careful, right? Back to the chats here. Jake says, exactly. Prep work. You have to go into it willing to receive and learn. And willingness to learn is not universal. A lot of people come to therapy just to be protected or satiated. And I promise you that willingness to learn is extremely, extremely, extremely important. So do not, I repeat, do not just randomly try psychedelics. It's bad for you. Your willingness to see things and experience things will change too, right? Because you might start therapy and like your therapist, but what if something shows up? What if a defense mechanism shows up? What if a trauma shows up, etc.? And now all these plans you've made, you should probably delay them, for instance, before you do a trip. Psychedelics are not party drugs. I know kids do them. I know in rave culture in particular, it's like Molly and MDMA and ecstasy and all this stuff. Like they want to go get high and have a transcendent experience while they're drinking and dancing and sweating and overheating and all. And that's fine. If you want to go do that, go do that. I don't recommend it, but I get why people like it. My general encouragement is Be very, very careful. Jake says, like signal chats with Jonathan and colleagues. So like it's funny. So it's like some things are dangerous, like talking to your friends about dangerous things. Jonathan Cogburn says, we may have talked about this before, but my complaint about the discourse, the discussions about MDMA therapy is that MDMA wasn't the primary intervention. It was meant to potentiate or enhance a therapy intervention. And that's right. You can't just take a drug and then do nothing and get better. The whole purpose of any drug, whether it's a psychiatric medication like Risperdal or Lexapro or whatever, is to take the substance and then go do something differently, right? Good therapy, whatever the particular modality, whether it's psychiatry plus psychotherapy or psychotherapy alone or psychedelic assisted therapy, whatever the modality, your job is to go in there willing, interested, and then try to do something different. The idea that you're just going to go talk about your childhood and then you'll feel better is garbage. It's such garbage. The therapists who love a good story, who are there just listening like voyeurs, that's disgusting. You're not helping someone. You might think you're helping them feel understood, but the truth of the matter is that patient needs to be going out there and doing something different after every session. Now, what they do differently is completely up to the therapist, and it's subjective. And it's unique to the presenting problem and the diagnoses and the history and the trauma and the culture and all that stuff. But the idea that you're going to sit there and take a drug and be just like masturbating verbally out loud, that's bullshit. Free association is absolute bullshit. It doesn't do anything unless you take the insight and go somewhere and do something with it. That's where people change. People don't change just because they feel seen. Jonathan says, IFS guided visualization was used, which is one of my favorite interventions. It takes a lot for lasting change to occur. Nothing is a panacea. Exactly. Nothing is a panacea. Jake said, as I was reading Psychonaut guidance on how to approach mushrooms, or in my case, truffles, was going with an intentionality, but knowing that the substance was going to take you somewhere, right? So you can be as intent. That's the other thing about psychedelics is like you can do all sorts of cool prep work. You can talk to a therapist. You can talk to a psychedelic guide. You can do all sorts of stuff to prepare yourself for a trip. But I can tell you from both my personal experience and then also talking to patients about their experiences with psychedelics, it's 100% the case that as much prep work as you do, and you can do a lot of good prep work with very smart and reasonable people, something is going to come up. A good thing or a bad thing. It doesn't really matter. Something is going to come up and you're not going to be prepared for it. And that's okay. And then the question becomes, are you internally skilled or do you have the external support to walk through that thing that comes up unexpectedly as a trip? He said the pre-meditation required to get a place where it made sense to try was intense. And what came to me during the trips was valuable. Exactly. It's always life-changing if you do it right. But just because you're having a momentary life change doesn't mean you go practice that change and internalize it as something valuable long-term. Jonathan says, emotional verbal masturbation in quotes is my takeaway quote from today's. Exactly. It is. Like the idea that you come to therapy and you just verbally masturbate out loud, you just like, catharsis. You just like share whatever feels bad. You're venting. Like venting is fine. You're allowed to vent. I think venting is useful in some limited circumstances. The question is, what are you doing with it? Yeah, Jake says, something is going to come up. Exactly. Someone described a bad trip as resisting the wisdom offered, symbolic as it often is. Exactly, yeah. Bad trip doesn't mean nothing valuable happened. It just means you felt bad during the experience. That's all. But there's still stuff to learn. So again, in summary, the research, the way this conversation started was, there's a brand new preprint, so it's not published yet, but it probably will be, that shows that thanks to statistical fuckery, which is the name of my college, grad school, psychology nerd band, because of statistical fuckery, most of the trials, the small sample trials using psychedelics, are no better, generally speaking, than antidepressants, because there's the problem of blindedness and there's the problem of control and all these things. Yeah, that's called. So Jake says, plus there's an illuminated afterglow period after the trip. It will not last. You need to journal and capture what you learned. Exactly. That's called the integration phase. So integration is equally as important as the trip. In fact, it's more important because you can trip and get nothing out of it if you don't integrate afterwards. And so it's extremely important if you are considering psychedelics to be very cautious about who the provider is, because they might just have had good experiences themselves, and that's awesome. I've had good experiences, but just because I've had good experiences, that does not mean that I am interested at all in encouraging other people to do it. And the reason is because my experience is not going to be remotely like anybody else's experience, because I am different in thousands of ways. Neurologically, culturally, socially, genetically, and otherwise. And so it's very, 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 very important that if you are interested in psychedelic-assisted psychotherapy, that you do all of the prep work you need to do, that you find a provider who's not just whatever the research says or whatever my personal experience says, but someone who can really speak to the ins and outs and the challenges and the consequences of doing this kind of work. It's not just all shits and giggles and fun and I'm deep and profound and crap like that. It's very difficult work. Jake says, doctor, jokingly I assume, how can someone know if, say, ayahuasca is a good idea for them or someone else? I have known someone who did it and got ravaged by six-dimensional demons, etc. Others, it helped them with combat trauma and so forth. And so Jake's question is a great question. Like, what are the best predictors of someone being helped? What variables predict getting helped by like ayahuasca or similar drugs? And so we don't have great research on this because obviously it's not okay to study this in the United States and other cultures and Western cultures. To the extent that we know anything about, for instance, ayahuasca, there's dozens of things that can go right and there's dozens of things that could go wrong. And so the things that go wrong is maybe the preparation isn't correct, or maybe the person didn't do the appropriate prep work. Like we were just talking about, right? Like literally speaking, you can think ayahuasca is going to help you, but if you don't do the correct prep work, if you're not prepared, if you're not educated about what's about to happen to you, then you're going to go in there with false expectations, or you're going to go in there with false hope, or you're going to go in there with pessimism, or you're going to go in there with any number of things, and it's going to fuck you up professionally, clinically speaking. But then there's also like hipster shamans, right? You go up to Berkeley or whatever, and there's some white chick or dude or whatever who like doesn't know anything, and they think they're spiritual, or they've read some studies, or they had a good experience, and now they're going to be an ayahuasca shaman. And it's just like, don't do that. Don't go see the suburbanite, upper middle class, pseudo-intellectual who believes they're a shaman in Berkeley, California. It's such a waste of time and money. So sometimes the people who are doing it don't know what they're doing. Sometimes it's the wrong preparation. Sometimes your trauma is so bad, it's so severe, that you're probably not going to be able to tolerate what's going on. You know? And the thing he just said, I was about to actually just get to, so there's some synchronicity here. And he said, and yet others, absolute turbo normies who do 4 or 5 ayahuasca trips per year and become egomaniacs. It makes me ill. Yeah, like there's a lot of people that we call in therapy land, the world's worst theme park, we call them normies, right? So there's a lot of people who are like mostly okay, but stressed out by the lifestyle they've chosen. They've chosen to live a hyper-capitalist, hyper-productive life like Silicon Valley nerds or whatever, or they have like really expensive lifestyle habits, or they've got, you know, crappy parents and crappy mentors and crappy support, but they're busting their ass to make their life work. There's like a lot of normal life stress that people have that's not really diagnosable. And so these normies who don't have a diagnosis with mental illness might go try to like, you know, escape reality 6 or 7 times a year, or the Silicon Valley folks who are like tripping on mushrooms to just like feel better as they take on ridiculously stupid tasks in their life. And like, that's not the purpose of psychedelics. The purpose of psychedelics is not to escape. It is not to run away from yourself. And if you do that, it'll probably beat you up real bad, especially ayahuasca in particular. You know, like if you think rage is a good thing, if you like your rage, if you've identified with your rage and you have zero desire to feel better, ayahuasca is probably not going to work great for you, is my guess. It's a guess, but you know, it's probably not going to be good for you. And so my general hope for most people is if you're a turbo normie, as Jake says, or you're trying to escape from your very stressful life that you've, you know, saddled yourself with, or if you have very severe mental health problems and you're not really like ready to handle something as arduous as a psychedelic trip, don't do it. It's not a good idea. It doesn't seem like a good idea. It's probably not a good idea. So my hope for everyone is you're extremely cautious and extremely skeptical at trying anything psychedelic, because although I think it can help a lot of people, I think there's not a lot of great data, and this new paper that just came out proves that, you know, essentially, you know, there's a lot of bodies buried in the data, and it's not much better than antidepressants. And antidepressants are safer in many ways and less volatile. So there's pros and cons to each approach. Jake says, not to jump topics, but the Texas Ibogaine initiative seems promising. I'm helping with replication here. Oh, great. Awesome. So I love that. I hope that every state that's willing to do initiatives to fund research, to create practices and standards and ethics and safety, I hope it happens, because I think it'd be awesome. I think it'd be absolutely awesome. You know, I hope so. But we got to do it right. We got to do it with ethics in mind. We got to do it with patient safety and differential diagnosis, which is one of the topics in mind. So, topic 1 out of the way. We did it. We did it, folks. Just want to talk about some fun interaction that I had. At Tweet a Therapist. She's one of my favorites, the No BS Therapist. I'm going to post it real quick. 4 days ago, she said, I feel like I'm missing something. I don't think there's a shortage of therapists at all. Between telehealth and people being licensed in multiple states, this problem has basically been near rectified. Thoughts welcome. So my response was, I don't think there's a shortage of therapists whatsoever. There's a drastic shortage of people who understand differential diagnosis, countertransference, family systems theory, and effective interventions. So there's been a long-standing narrative, at least in the United States, that, you know, there's not enough therapists, there's not enough psychiatrists. It's actually true, there's not enough psychiatrists, to be fair. But there's tons and tons of therapists. There's therapy mills everywhere. There's therapy grad school mills everywhere. And I'm grateful that I work at a grad program that's real university, good people, do a good job. Excellent colleagues. Couldn't be more grateful to work with them. I feel very, very grateful. Good school. The problem with being a bunch of therapists, there's so many therapists. The problem is, for me at least, the problem is you can have decent training or even a good supervisor, but there's a lot of problems with the therapy culture that exists outside of graduate psychology. So you might have even gone to a good grad school, but once you leave grad school and you do your internship to get your hours to get licensed, or you get your first job after you get your license, right? Sometimes it's in clinics and rehabs like the ones I've run in my career. Sometimes it's, private practice that just jump straight to private practice. And so the problem with therapy culture is really, really inundated with pop psychology, pseudo spirituality, and just a lot of practitioners who are very mentally unwell, who are pushing their own projections and unwellness onto their colleagues. And so Jake is mentioning here like affirmation and validation. Like, there's nothing wrong with using affirmation and validation as a tool, but every tool is only appropriate in certain circumstances. And so you have to be very thoughtful in how you use these tools. And your therapeutic attitude specifically can't just be all Carl Rogers and bullshit. Like, I get why people like the humanistic, existential, unconditional positive regard. That's all fine. I think you should not be a dick or an asshole to your patients. That's bad. I've done that, and I've apologized and admitted I was wrong. But the problem with going to the exact opposite end of the spectrum is that when you maintain a non-neutral attitude towards your patient, you're now going to be more sucked into some transference dynamic, which is their side of it, or on your side of it, a countertransference dynamic. And so if you're not appropriately skeptical of countertransference, which is one of the things I said in response to her, like, therapists are regular people. I don't know how else to say this, but like, a lot of therapists, unfortunately, think they're special because they've gone to graduate school or they have a doctorate degree or an MD and you're a psychiatrist. And like, you're not special. You've had special training. You might even have specialized skills. So like, if you're really good at ERP for OCD, that's a specialized skill, and God bless you for like doing that. That doesn't mean you're a special person. And a lot of therapists confuse their training and their skills with how specially insightful they are or healthy they are. And most therapists are not very healthy. Most therapists are actually not very healthy. They're like not very aware of their countertransference, as I said. They're not very aware of their bias and their cultural differences and all the stuff that makes them want to be nice. Like, a lot of therapists want to be liked. Some of you don't know this, but like, a lot of therapists really want to be liked. They sit as a person in power, which is true, where I'm the all-knowing whatever it is because I want to feel good about my smartness and my specialness, which is not your job, by the way. Your job is not to be so smart and special that your patients like you and want to keep seeing you. And so there's a lot of problems in psychotherapy land, the world's worst theme park. So be careful. Be careful in choosing your therapists. If your therapist has an entirely positive view of themselves or they think they're great, I might run from them. Jake says, I've had young women especially come to me after being in therapy for 5 to 8 years, and I'm the first person to ever have helped them see that their patterns are mostly under their control. Your patterns of behavior are very much under your control. You can influence those patterns of behavior. That doesn't mean that you can permanently change your personality, for instance, but you can certainly do something to mediate and mitigate the effects of your personality on the world around you. You can adapt. Humans are very adaptable. We're one of the most flexible species on the planet. So IQ, fairly static. Personality traits, fairly static. But what do you do with those things? How do you mitigate your presence in the world? How do you adapt to the world when needed, right? He says, sometimes they'll cry. No one ever told them. Yeah, it's sad. Jonathan says, lots of people with credentials who aren't living by effective self-limiting principles and action-guiding axioms. And so there's a lot of psychotherapies that actually talk about principles now. Like, I think it's no mystery why ACT, acceptance and commitment therapy, became super popular in the last 15 or so years. Because the lack of values in the culture generally has prompted people to want to be more focused on values and being clear about their values and highlighting discrepancies between their behavior and their values and figuring out what to do with those discrepancies between their behavior and their values. Like MI does that, and it's been doing that since the 80s. And ACT has been doing that at least for the last decade effectively. And so many good therapists out there are mediocre because they don't pay attention to themselves. They don't understand their transference. They don't get it. Jake says, well, with men, we get a baseline of both their mental health, but separately their 1 rep max, bench, squat, deadlift. I don't deadlift, so I like my back. So I just refuse to deadlift. I will do all sorts of other things to have better posture and a better back and stronger hips, etc. I guess I'm not a real man though. So moving right along. Moving right along. I'm going to get all sorts of shit for that comment, by the way. All right. I want to talk about this. Jake says, amazingly, as their 1 rep maxes go up, their mental wellness goes up. Yeah, getting stronger is actually good for your mental health, by the way, for whatever it's worth. Like being jacked isn't definitely going to, how would you say it? You cannot get so jacked that you're mentally well, but it certainly helps. All right. I was trying to get to this last week, but I didn't actually get to this. So there's a psychiatrist who used to be on the DSM committee, so the Diagnostic and Statistical Manual is like the diagnostic Bible, where the diagnoses come from, what the research says about them. So Alan Francis, I love him, is one of my favorites on Twitter. And I'm just going to tweet it real quick. So this is years ago he posted this, but he's reposting it. So this is a topic. This is a topic that I think is really worth everyone discussing. So evidence-based medicine, evidence-based therapy, evidence-based this, that, and the other, right? So like I was just saying with the psychedelic research, a lot of consumers, but also a lot of professionals, clinicians, psychiatrists, psychologists, they don't really fully understand what the research actually says, number one, but they also don't understand the concept of generalization. Just because you read a paper that said ERP, exposure plus response prevention, worked for OCD in this sample of people, that doesn't mean it generalizes to other samples. Or how well does it generalize to other types of people? So Alan says, evidence-based medicine often generalizes poorly, as in not well, to everyday practice because, number one, patients in controlled studies aren't like the unselected patients. I'll explain more about that. Number two, research settings, clinics, hospitals, differ from real life. Number three, biases influence data analyses. So evidence-based medicine provides necessary guidance but shouldn't be worshipped. I'm going to say that again. These are his words. Evidence-based medicine provides necessary guidance, but shouldn't be worshipped. So here's the deal. Here's the deal, folks. He said the reason that evidence-based medicine doesn't generalize very well is because of three things. So let's walk through these three things very clearly and simply. Again, the whole spirit of this podcast is let's make an informed consumer base. That's it. I just want you to be so informed that you can make better choices with your healthcare providers, with your therapist, etc. So number one, he said, patients in controlled studies aren't like unselected patients. I teach an entire course at my university about just this topic. I teach a course called Research Synthesis and Analysis for MFTs. I teach them how to understand and critically analyze research. And every one of them loves it. Every one of them's terrified at the beginning because it's like, oh my God, statistics. But at the end, they're like, wow, I didn't know that was true. I didn't know how this worked. I didn't know where all these bodies were buried. They're shocked. And they love research more because of the class. Because they now can actually understand and read it and analyze statistics and critique things. So let's speak to what he was just saying. Number one, patients in controlled studies aren't like unselected patients. So what do these patients look like? So if you look at your classic study, you find a research paper on Google Scholar or something, and you pull it up, and it's like a sample of 60 people at some hospital somewhere, or some clinic, or some rehab somewhere. So automatically, if your sample of patients for this study come from a rehab, like ones that I've run in my career, or a psych hospital, or an outpatient clinic, automatically there's a bunch of variables that are drastically different. Variable number one is how sick are these people? Most of these very high level of care places, very intense acute places, pull for people with very serious impairing symptoms. But the problem is the vast majority of people with the diagnosis are mild or moderate, not severe. Severe diagnoses are statistically very rare. So why would you try to generalize a study that looked at a very, very, very sick person to a not so sick person. That doesn't make a lot of sense to me. Another variable that's automatically different just because you've now done a study at like a rehab or something is most people that come to these very expensive intensive clinics or whatever, or psych hospitals, they have 3 or 4 serious problems. They've got serious suicidal ideation, serious trauma, maybe a serious drug problem mixed in there, maybe serious like acculturation issues or sexuality issues or whatever it is. And so automatically you're trying this one intervention, DBT, CBT, ACT, psychodynamic therapy. And you're saying you're trying to treat this one problem, but in reality, there are all these co-occurring issues. But also, a second problem to that is most of the time, these studies say we did not select people who had a co-occurring drug problem or psychosis or whatever it is. So if you had what most very seriously ill people have, which is multiple diagnoses, then you couldn't even be in the study. So this really weird artificial sample of people with only schizophrenia or only depression or only PTSD, which is not realistic. Most people who are very mentally ill have a couple of things going on at once. And so most of the research cannot generalize because there's usually a drug problem. Now, I'm very biased because I worked in Rehabistan, one of the most crazy industries on the planet. And like in Rehabistan, everyone's got 3 or 4 things going on and everyone downplays their drug use and all this stuff. And so it's very, 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 very important. Not everyone, but like a lot of people. And so like, it's very rare that someone just has PTSD. It's usually PTSD plus a substance problem or a marital problem or whatever. Jonathan Cogburn says, life equals confounding factors. Exactly. There's so many mediators, moderators, and confounds. Oh my. Just to go back to what Jake said, he said, smart like tractor, strong like ox. Freud. Yes, I'm sure Freud said that. But like, it's so incredulous to believe that these studies are going to generalize. It's just incredulous. Number 2, research settings differ from real life. I already talked about that, but like a psych hospital, what works in a psych hospital is not going to work in an outpatient therapy clinic. It's just not. Those are wildly different settings with different types of people, different interventions. Number 3, biases influence data analyses. So for those of you who don't know this, a lot of people, a lot of human beings believe that scientists, especially social scientists, psychiatrists, psychologists, sociologists, are these pillars of morality and these pillars of self-awareness. And I promise you that people like myself are just regular people. And so we are just as prone to biases, egotism, and all this stuff that makes us do bad stuff. So for instance, a lot of researchers, like there's thousands of papers that are retracted every year from scientific journals, and only 20% of the time, I think, it's because of honest mistakes. Most of the time, people are manipulating their data, p-hacking, all this stuff. And so researchers are very biased, and they do often choose certain analyses, clean the data a certain type of way, fill in data gaps a certain type of way to prove a point. So be very careful if you think researchers are all perfectly loving, well and good, like organically, neutrally looking at the data. That's not how it works. Researchers are just people. Now, some researchers are more on the spectrum or more neutral or more aware of their biases. So they're more prone to maybe doing less of that shenanigan stuff that makes it biased garbage. So thank you, Alan. I appreciate you oh so much. Jake says, this is why talking with overeducated people is difficult. Empiricism is a useful tool, but it requires rationalism and wisdom to put it together. The data points for the macro. Yeah, there's always a macro, there's always a micro. And you have to look at both. Or they're ideologically captured. And a lot of people are politically and otherwise ideologically captured. Um, I'm going to talk about just so many good things I've saved to talk about. So forgive me for scrolling a little bit. I'll talk about intelligence next time. I don't think that that's useful today specifically, but I think generally speaking, what I would say is there's a lot of average people. There's a lot of below average people. Over 50% of people are either average or below average. Keep that in mind when talking to people. Um, let's do one more from no. Let's switch it up real quick. Um, okay, I'm just posting it real quick. Okay, Dr. Dominic Ng, I think, at DrDominicNG, posted this 4 days ago. He said, brand new Swedish study finds people who develop ALS were more likely to have used common psychiatric medications years before their diagnosis. So this is one of those correlations is not causation things, but keep it in mind. So ALS is a very difficult and usually, I think, fatal disease. And apparently there's a correlation between taking like benzodiazepines and a greater risk of ALS, sleep medications, 21% increased higher risk, and antidepressants, 26% higher risk. So basically, most of the time, these psychiatric medications, especially longer term, are hard on your brain. So they may be helping in some ways, right? So I'm not anti-medication, just so everyone's clear. But the truth of the matter is, it's very well known. Every psychiatrist can tell you, and I'm not a psychiatrist, so don't sue me. I'm not giving medical advice. I'm just speaking at the level of like I teach psychopharmacology for my university, and I have for years. So I'm not saying something proprietary or secret or conspiratorial or whatever. Most psych meds are very effective for people who are acutely ill. And that's not a secret, and that's awesome. Now, the question becomes longer term. Once your acute symptoms of insomnia, once your acute symptoms of depression have started to improve, how important are those medications ongoing? That's a question. We don't know. There is no one-size-fits-all answer, right? And so the question then becomes specifically, what are the pros and cons of these medications across time, right? And what are the consequences specifically to your brain health? Because studies like the one that I just retweeted from Dr. Ng kind of support the idea that there may be lots of unintended consequences of these psychiatric medications. Like, I think it's a pretty uncontroversial thing to say that most benzodiazepines are terrible for your brain. And the only reason they were created is because their precursors were even worse for you. So, like, generally speaking, it's not a great idea to take anything forever in large, long doses. It's just not. But how much, how long you should take medications? Good question. Talk to your healthcare provider. Have an informed discussion. Talk about the research you've read, if you've read some as a patient. Ask the psychiatrist what research they've read. Now, the problem is a large percentage of people, I think it's over 50% of people in the US at least, get their psych meds from their general practice doctor who knows probably nothing about psych meds. I probably know more than most general practice doctors about psych meds. But the point I'm trying to make is you have to be careful because some people who are very ill might actually need medications longer term. And so I'm not anti-med, I'm not pro-med. I'm pro using tools appropriately. Just like we were talking about with psychedelics and stuff. And so please be careful. You don't have to stay on a medication forever if you don't think it's good for you. There is a deprescription movement that exists out there, and I'm not necessarily pro or anti it, but like, just be careful because fads are fads. Fads catch people's interest because there's a large group of people who have an interest in that fad, but that doesn't mean that fad is good for you. EMDR, anti-psychiatry, all this stuff, these are fads, and they will dissipate with time. Okay, so I'll end with this one. So this is again No BS Therapist. She posted this. I'm just going to retweet it and not describe it right now. She said, "Therapist on therapist hate is real." In parentheses, I just read a few 1-star reviews of a local PsyD and am currently fired up. So here's what I will say. I don't hate my colleagues. This is what I said. I want them to get better. It's possible to become more competent and more ethical. Kendra just chatted. I'll get back to that in a second. Kendra just said, what about taking meds on or off? Is there research on the effects of being on meds for a certain period and then going off for a while, then back on? Yeah. So Kendra, again, I can't give you medical advice. I'm not a psychiatrist. I'm not your psychiatrist. So neither of those things are true. I'm not a psychiatrist. I'm not your psychiatrist. So there's different types of medications out there, and some of them are used more temporarily. So for instance, there's a disorder called premenstrual dysphoric disorder, PMDD. And so I believe there's a number of studies that show it can be effective if people take like a Lexapro, an antidepressant, temporarily to help stave off the symptoms of PMDD. Now, again, that's not psychiatric advice. I'm just discussing a couple of studies that are well documented. And so it's complicated because depending upon the medical condition, the psychiatric condition, sometimes you can take them less frequently, more frequently, consistently, less consistently. I had a patient once, so I was the therapist for this patient years ago, who was on stimulants for ADHD. He talked with his psychiatrist, and the psychiatrist apparently reportedly told him that he didn't have to take his ADHD medications every day. So apparently some people, and there's some research to this effect, some people with ADHD only take their medications when they're about to do very work-intensive, attention-intensive things. Now, again, I'm not a psychiatrist. I'm not giving medical advice. There's different types of research that say different things because the research is not one-dimensional. It's multidimensional for different types of people with different co-occurring conditions and all these things. So please talk to your provider about either if you're having adverse effects, go talk to a psychiatrist, psychiatric nurse, or if you're getting them from your GP, talk to them. Jake said, I had a gal I worked with who was on 8 pills when we first started working together. She was of the idea that she would be on them forever, which is true for a lot of people. They think they're going to take meds forever. She's now on 2 and much happier and vibrant. Good. Some people don't need 8 meds. Some people might, in rare cases. Some people do. So I want to get back to this post before I wrap things up today. So No BS Therapist, again, said, therapists on therapist hate is real. So I want to make sure it's abundantly clear to everyone who ever sees or hears me talk on episodes of UnShrink Me. I know I have other content on YouTube that's not specifically about this. My main job, the whole reason I do this is I want a more informed consumer base. I want everyone who consumes therapy, psychiatry, who goes to see a therapist or a coach or whatever. I just want you to have a better understanding of these complicated topics and how complicated it is. Also, I want you to understand how complicated therapists are and how messy we are and how it's not like everyone's great and everyone's healed just because they have a degree and a license. So I don't hate any therapists. I don't hate any psychiatrist. I want everyone to understand all the critical things I'm saying, all the critical sounding things I'm saying are not because I want you to be disenfranchised with the profession. I want you to be critical consumers. I want you to get your money's worth. I want you to not be hurt. And I want you to be helped. I don't want to bash a particular therapist. I don't want you to, I'm not here to bash a particular psychiatrist or treatment program. If I call somebody out by name, it's usually because they said something stupid online. I don't necessarily know if they're a good or a bad therapist because I would have to go talk to them at length to know anything about that. So this is not the anti-psychiatry, anti-therapy podcast. This is the criticizing the profession and all the bullshit in the profession podcast. Because criticism is what helps us grow and get better and be more accountable. That's why I do this. And that's why I'm glad you're all here. Kendra says, that makes sense. It's like physical illness. It ebbs and flows, and so does the need for meds or lack thereof. Yeah. Your needs for medications might change over time. So go talk to a doctor who's willing to be reasonable. Jake said her MD had never even discussed therapy with her, just medicated her. Yeah, and most doctors don't really understand therapy. Most people have like a vague sense of what therapy is and why it might help, but general practitioners, they don't know anything about therapy, generally. And unfortunately, most therapists also don't really understand the research for the things they're trying to use. So find someone who's willing to either go get more educated or be more educated, or find someone who's absolutely educated, who gets it, who is willing to be thoughtful and critical, because they're out there. There's plenty of good practitioners. They're just harder to find because there's a sea of people who just want to help. And those are dangerous words, in my opinion. Finally, Kendra says, research could be the difference between getting the help we need or digging a deeper mental hole. Absolutely. If you do things that aren't research informed, you might be hurting yourself unintentionally. So we have the responsibility as patients to do our homework for our own sake. Yes, Kendra. Heck yes. Fuck yeah. Patients have a responsibility just like practitioners have a responsibility. It is the patient's responsibility to do your homework, and it is the practitioner's responsibility to not only do your homework and know what the hell you're talking about, but also to understand yourself. The best clinicians, the best interns I've worked with are the people who know themselves and also know what they don't know. And if you know yourself enough, you know how to not hurt people. And if you know what you don't know, you probably know how to help people to some degree. But also, Kendra, you're right. Patients have a responsibility to do their homework. And you have all sorts of access to podcasts like this and research. Everyone can go to Google Scholar. Everyone has a smartphone basically in the US. You can go see what the research says about things, and you can go ask a professional. Like, my DMs are always going to be open on Twitter because I want people to ask questions. I want people to ask for help, and I'll help you find the right referral or answer your questions about the research because it's complicated and most people don't understand it. So that's why I do this. And I'm so glad you all came out to chat today. It's so much more fun when people come hang out. So thank you all for being here. I'll see you next Saturday, hopefully. As always, please like, share, and subscribe. Let's get the word out. Spread the word. Dr. Lockwood is here to help you become a more informed consumer. I just want you to maybe get hurt less or make a better choice, a more informed choice. I'm not perfect. I might even say incorrect things. And if someone catches me on this podcast saying something incorrect, I want you to call me out publicly. I want you to comment on the podcast. I want you to call me out on Twitter. I want people to call me out as frequently as humanly possible. I want so much hate for the things that I say that it sharpens everything that I say, because I am not afraid of criticism. I am pro-criticism, especially if it's in the spirit of me doing things better. And we can all do things better, and I can certainly do things better. So please like, share, and subscribe. Please get the word out. Let's grow this thing so that more people can have access to good information, good conversations, because I consider what happened today with all the chats a conversation. And I think conversations are the cure to society's problems, in my opinion. I don't think politics is the solution. I think conversation is the solution, because conversation will inspire a small group of people to go do things differently. And that's what's awesome about therapy. And as always, I try to end my podcast with a dad joke. So here we go. I once worked with a baseball player. Nice guy. Super smart guy. Probably didn't even need to be a baseball player, but he just loved playing the game. He could have been a biologist or a scientist if he wanted to be. But this baseball player, he was having a really hard time. He just retired. He was in his mid-40s. He was having a hard time finding a wife. And that's not weird. A lot of athletes have a hard time with relationships. And I'll tell you all right now that if you're a professional of some kind, one of the most important things you can do is find a good relationship. It's good for your mental health. It's good for your career. It's good for your bank account, for sure. So this baseball player was with me because he had a lot of depression leaving his career, like being a Major League Baseball player. But he also was having a hard time with like, who am I and who do I date and all this stuff. So he finally found someone, he thought, and he took her on like 3 dates. So on the first date, it was just this classic like coffee, go get to know you. And he told me, he came into session the next day and said, Doc, she's kind of shy. She doesn't talk a whole lot. So I did most of the talking. I said, you know what? Sometimes it's like that, you know? So just like keep giving it a try, etc. So we went on a second date, and there's this classic like movie and dinner thing, and they even hooked up and they had a good time, but like she wasn't very responsive via text after the second date. And so he came back to session. He's like, I'm on the fence because it seemed like we had a good time. The sex was good. The movie was fun. The dinner was good. Conversation was okay. Wasn't great. I said, I don't know. I mean, if you want to keep seeing her, go keep seeing her. You know, if you don't have to. There's other people, right? And so he decided to go on a third date. He asked her out on a third date, and they went to a ball game because he's a baseball player and she knew he was a baseball player. She also said she liked baseball. And so they went to this third date, and he said, you know, we had a good time. And came back to therapy the next week, said, had a good time, held hands, kissed at the baseball game, all that stuff. And he dropped her off at home, yada, 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 ghosted him. She didn't respond to any of his text messages. He tried to call her. She didn't respond. Ghosted. And he came back to therapy the next week, extremely depressed, like very, very sad, very, very like down on himself. He's like, I don't know what's wrong with me. Like, I've got decent money. I have this career. I know I'm still trying to figure out what I'm doing with my life, but like, I don't know what happened. I tried my hardest to be funny and charming. And it's just, you know, I was like, sometimes it happens, man, is what I told him. I was like, you know, sometimes we're just not a good fit. He's like, but yeah, but like I tried so hard. I don't get it. And I feel so stuck and so lost. And I said, you know, there's probably something to learn from your career here, because sometimes, you know, 3 strikes, you're out. All right. Have a good day. Have a good week. Take good care of yourself. Eat good food. Sleep good. Have good sex. Do fun things. Take good care of yourself.